Welcome everyone to today's third installment of the Renal Pathology Patient Webinar Series, with today's focus being on lupus nephritis. So my name is Ben Adam. I'm a pathologist at the University of Alberta Hospital in Edmonton, Canada, and my co-moderator today is Kammi Henriksen from the University of Chicago. So I'm just going to start before I introduce our speaker for today with a few housekeeping items. So as a reminder for those that may not know or are tuning into the series for the first time, the Renal Pathology Society is a nonprofit organization committed to the improvement and dissemination of knowledge regarding the pathology and pathophysiology of kidney disease. The RPS promotes excellence in diagnosis, fosters basic clinical and translational research, encourages training and education in renal disease, and sponsors multiple international conferences and symposia, and brings news and updates pertaining to renal pathology to its members around the world. So the goal of this particular patient webinar series is to further support interactions between pathologists and patients with kidney disease by providing patient-centered educational content focusing on the basics of renal pathology and some common kidney diseases. So through this series, the RPS hopes to empower patients and pathologists alike, and thus work towards minimizing the burden of kidney disease around the world. And I just want to acknowledge that this series is supported by an educational grant from Trivier Therapeutics. So thank you very much to them for their support. So a couple quick housekeeping items. If you have any questions during the presentation, please enter them into the chat. And we should have lots of time at the end to address them all. And then after the session, all attendees should be receiving an invitation to complete a short Survey Monkey poll to collect your feedback and help us improve future webinars. So please watch your inboxes for that. Okay, so without further ado, it is my great pleasure to introduce Dr. Tony Chang, who will be giving today's webinar titled The Pathology of Lupus Nephritis. So Dr. Chang is a professor in the Department of Pathology at the University of Chicago. He is Associate Director of the Residency Program and Director of the Renal Pathology Fellowship Program at University of Chicago. He was also past president of the Renal Pathology Society as well as the Chicago Pathology Society. He has taught over 30 educational courses at annual meetings for the American Society of Nephrology, the College of American Pathologists, the US and Canadian Academy of Pathology, and the American Urological Association. And he's given lupus nephritis workshop at the American College of Rheumatology as well. So thank you again, Dr. Chang, for being with us here today, and I will pass it over to you.
All right, well, thanks so much for having me. It's a real pleasure to see so many people that are interested in discussing lupus nephritis this morning. Very briefly, I have a few disclosures, although they're not particularly relevant for my talk. We're really not going to focus on therapies very much, but I do consult for Alexion and GlaxoSmithKline. So let's dive right in because there's a lot to cover with lupus nephritis, and I think one of the things to really acknowledge right off the bat is that this is a very complex topic. In fact, this is probably the most complex topic within renal pathology, and it's important to acknowledge that because it can be tough to wrap your head around this disease. As we all know, it's particularly common. It affects anywhere from 50 to 80% of lupus patients. It remains a major cause of morbidity and mortality. We've made a lot of progress over the last many decades, but there's still plenty of room for improvement when you start looking at 5-year and 10-year renal survival numbers. And the incidence of end-stage renal disease still can be fairly high, fairly substantial. One of the real challenges remains that there is a wide spectrum of disease, and part of what's contributing to the complexity of lupus nephritis is that there are probably at least 3 or 4 mechanisms in the glomerular injury that we are trying to sort out when we're looking at the kidney biopsies. And then potentially there's other mechanisms that are impacting the tubular interstitial compartment as well as the vascular compartment. And we'll touch on all of those during the next 45 minutes or so. So the lupus nephritis classification really kind of started several decades ago. This is almost like 50 years ago now. And you can see that the framework of the lupus classification has essentially remained the same regarding class 1, class 2, 3, 4, and 5. And roughly every 10 years or so, this gets modified. And we're not going to go into these in too much detail, but this is just to provide this sort of background. And here's another one in 1995 that with more revisions, and then really a major one here in 2003, where we're really parsing everything out as far as we possibly can. And I guess the good news is that I think on a light microscopic level, you can't possibly dissect lupus nephritis any further. And so until there's a molecular classification, this is probably the limit. Now, in 2018, there was the latest revision of this classification published here in Kidney International. And actually, we've kind of swung the pendulum back towards somewhat simplifying or not making things nearly so complex. And we can talk about some of the rationale that went into sort of this somewhat simplification or sort of return of the lupus nephritis classifications, where now it looks very similar to that initial one back in the early 70s. All right, so let's dive right in. Lupus class 1 lupus nephritis, you basically have very normal looking glomeruli, right? And the only way of detecting the presence of immune complexes is through immunofluorescence or electron microscopy. And here on IF, we're able to pick up some of the mesangial deposits here. It's very subtle. The intensity is not very strong. And so, on the EM, we would also expect electron-dense deposits in the mesangial areas. And so this is enough for diagnosis of class 1 lupus nephritis. And I should say, when we make a diagnosis of lupus nephritis, I really want to make sure that clinically the diagnosis of lupus has been well established. There's now more and more pressure from clinicians for the biopsy potentially to establish that diagnosis. And I certainly don't feel particularly comfortable with that, because one thing to keep in mind is that there's really nothing in the biopsy that is absolutely specific for lupus nephritis, maybe with the exception of the hematoxylin bodies, but typically we'll show you some of those lesions. That's exceedingly rare. And whenever I see those lesions, those are in patients that have rip-roaring lupus, and it's not even a question, right? You're not going to really see those findings in a borderline case, for example. So that's something to really keep in mind. Before we put a label of lupus nephritis on a patient, we really want to make sure that the clinical diagnosis of lupus has been very well established. So class 2 lupus nephritis, potentially you could think of it as an extension of class 1 lupus. Maybe it's a more severe form of class 1, where you have a lot of mesangial hypercellularity that's now apparent by light microscopy. And you will also be able to detect the immune complexes that are corresponding with that mesangial hypercellularity. Here on this section, you can see that a lot of the mesangial areas are hypercellular, but the capillary loops still remain patent. And so that's a useful clue that there's really not significant endocapillary hypercellularity, or there's not a significant influx of leukocytes, that the hypercellularity is confined to the mesangial areas. And the immunofluorescence, I'm not showing you the full house panel, but this is just some of the representative ones that were fairly bright and of strong intensity. And you can see that the IgG is primarily staining the mesangial areas. So this is a very classic pattern that we would expect for class 2 lupus nephritis. And the EM also demonstrates the corresponding electron-dense deposits that are mostly confined to the mesangial areas. And one thing to keep in mind is that that's really a compartment that is sort of shielded from the circulation. So this is not an inflammatory, diagnosis, right? It's not an inflammatory lesion. Somewhat similar to membranous nephropathy, where the subepithelial deposits are shielded from the circulation. So class 2 lupus nephritis, I think officially you could call it mesangial proliferative lupus nephritis, but I've really gotten rid of the term proliferative just from my reports because, particularly when I'm talking with the clinician on the phone, sometimes, the connection is not great. And when they hear proliferative, they're automatically thinking about class 3 or class 4 lupus nephritis. And really, I want to avoid any possibility of miscommunication. So I've really kind of started to remove that from my final diagnoses. So class 3 and class 4 lupus nephritis represent, class 3 and class 4 are qualitatively identical, right? The difference between class 3 and class 4 really is a quantitative one. And so we'll talk about some of those differences, but it's somewhat arbitrary, right? The cutoff is that if you have active lesions or chronic lesions involving fewer than 50% of the glomeruli, that's class 3. And if you have, 50% or greater involvement, that's class 4. And so this is where, sampling is always important. We certainly prefer as much tissue as possible, and our confidence in our classification or the accuracy of our classification starts to increase when we have at least 10 glomeruli. But, even if you had 50 glomeruli, you can start, playing the game of, hey, if you had 25 glomeruli with active lesions, that's class 4. But if you only had 24 glomeruli with active lesions, that's class 3. And so this is why the latest revision of the lupus nephritis classification is recommending the use of the activity and chronicity indices to allow you to really convey some more of those details that, just lumping things into class 3 or class 4 lupus can't provide. And so let's focus on class 3 and class 4 lupus nephritis, and particularly the active lesions. You have this long list of findings which potentially starts to overload the neurons, right? And so one of the things that I like to do with this list is really separate it into 2 parts. The first part represents, so when you have rupture of the GBMs, that can lead to fibrinoid necrosis and then cellular or fibrocellular crescent formation, right? So these 3 findings are all associated and related to one another. And so that's something I think that's important to keep in mind. And then the last 4 items are all related towards immune complex deposition. When you have prominent immune complex deposition, particularly in the subendothelial compartment, that is, I think of the immune complexes as being immunogenic, and it can induce an influx of inflammatory cells. And so that's going to lead to endocapillary hypercellularity and potentially Karyorexis, okay? And then these last 2 represent prominent immune complex deposition, which starts off in the form of wire loop deposits, which represents, prominent accumulation of subendothelial immune complexes. And when that becomes really, really prominent, it can look like it's filling up the entire capillary lumen, and those are known as Hyaline Thrombi, which is a really terrible term because they're not true thrombi, right? They don't contain platelets or fibrin or anything like that. So these are just really large immune complexes. And so the chronic lesions really often represent, right, the scarring or the chronic phase of these active lesions. And so when we talk about activity, right, it's best when your biopsy has no activity and no chronicity, right? Obviously, that's not necessarily what we deal with on a regular basis. And so the more active the biopsy, right, that represents how much ongoing injury that is potentially amenable to therapy, that could be potentially reversed, right? And chronicity represents scarring or irreversible damage, and that's not something that we would specifically treat yet. Maybe someday there'll be therapies that will allow us to treat chronicity, but not currently. And so to be able to convey how much activity is there and how much chronicity is there, the NIH activity and chronicity indices are helpful to do that. And so the activity index consists of 6 parameters, and it makes up 24 points. And because cellular crescents, cellular fibrocellular crescents, and fibrinoid necrosis are considered severe injuries, those parameters are multiplied by 2, right? And so you can see the scoring system here is if you have less than 25% involvement, it gets a score of 1, 25 to 50% is a score of 2, and greater than 50% is a score of 3. And so potentially fibrinoid necrosis and crescent formation can take up 12 of the 24 points. And then you have these other parameters that you can actually score as well. And one of the things that I would point out is that, you know, this parameter in my hands, I rarely get up to 20 points even. I would say 18 is typically my highest. And so for me, a score of 12 is actually very, very high. And so this is sort of one of the drawbacks of this activity index where, I mean, if you look at the score of 12, it'll look like it's kind of moderate, but that's probably not, in my mind, a fair way of conveying sort of how much activity is actually in that biopsy. Potentially, this is something that we can actually maybe modify in the future, because, you know, it should really be and or in terms of the crescents and fibrinoid necrosis. I think that that's one of the probably weaknesses here. And the same thing with the chronicity index. It's pretty rare for me to exceed 8 or 9 points. And part of that problem is that the glomerular scarring and fibrous crescents are probably essentially kind of the same or not necessarily mutually exclusive like this index seems to imply. And the irony, and we'll talk about this in a bit, you know, tubular atrophy and interstitial fibrosis is way more important than glomerular scarring. And that's actually turns out to be true regarding interstitial inflammation. So the current lupus nephritis classification is very glomerulocentric. And we've seen, and I'll show you some of our data that demonstrates that actually this simple parameter trumps all of these other glomerular parameters, however you want to look at it. The extent of interstitial inflammation is actually more important than the degree of glomerular injury. So with the cellular crescents, one of the things to remember is that initially, right, when it's very acute, very recent injury, you have a lot of cellularity. The epithelial cells are very, very packed closely together. And this is actually indicates a very recent injury. And as this crescent ages, right, it becomes fibrocellular and then it becomes fibrous, okay? And one of the clues that potentially you're dealing with a fibrous crescent is that then Bowman's capsule really becomes disrupted and really eroded and degraded, and really you might only see remnants of Bowman's capsule. And here's another nice example that I like to illustrate to really demonstrate that, right, to remind us that the biopsy is a snapshot in time. And in this image, you can see that up here on the upper right, this crescent is actually now pretty much a fibrous crescent, right? And so this is the oldest injury. And in the glomerulus in the middle, we actually have 2 crescents, basically. There's one that's more fibrocellular here at the 6 o'clock position, and then you have a more acute hit that's sort of surrounding the rest of this glomerulus that happened more recently. And so that's something that these biopsies can potentially emphasize, right, that the injuries happen over a long period of time at different time points. Here's an example of fibrinoid necrosis with Karyorexis. You can see the inflammatory cells and sort of breaking apart in this lesion. And here's a very small cellular crescent over here. And then that often, when you have prominent immune complex deposition, that often goes along with endocapillary hypercellularity, which it used to be termed endocapillary proliferation, but we, I think, recognize that most of the hypercellularity is due to an influx of inflammatory cells, and it's not so clear that you actually have local proliferation of the resident glomerular cells. So let's talk a bit more about some of these wire loop deposits and hyaline thrombi, and then the more potentially specific finding of hematoxylin bodies. So the wire loop deposits represent prominent subendothelial immune complex deposition. And you can actually see that very nicely in this example, where you actually have then duplication of the glomerular basement membranes, because the endothelial cell and the podocytes secrete the matrix that make up the GBM. And so as the subendothelial immune complexes accumulate and push the endothelial cell away from the original glomerular basement membrane, it's going to lay down a second layer. So this finding tells you that this is a chronic injury process, right? This did not happen overnight when we're looking at a biopsy like this. And here's another example of that in an adjacent glomerular capillate. And then when these immune complexes become so prominent, they can actually fill up some of the capillary lumina, like we're seeing here. And one of the nice hints that you're dealing potentially with these pseudothrombi or prominent immune complexes is potentially this retraction artifact that you can kind of see here. And also, this is not a true thrombus because the staining quality is so homogeneous. You can see how uniform this pink staining is. And if we actually were looking at this under the microscope, one of the tricks that I think is very helpful is when you focus up and down, you can really see kind of a refractal nature to this, and particularly actually with the wire loops. That's a useful way to distinguish that potentially from, say, membranous lupus nephritis. And it's most helpful on the H&E, actually. In general, I don't use the H&E a whole lot. I really rely on the PS and the Jones stains. But with the wire loops and the hyaline thrombi, I would say the H&E is actually quite helpful to really appreciate the homogeneous staining quality of these lesions. I've seen very rare true thrombi with this retraction artifact. I think most thrombi, actual thrombi, you really don't have that retraction artifact. So I really rely on that quite heavily. These are hematoxylin bodies, these sort of brown globules that can accumulate in some of these glomerular capillaries, thought to represent naked nuclei, potentially maybe going along with that waste disposal hypothesis in lupus patients where, right, you're not able to clear out debris so effectively, so maybe it persists and hangs around, and then you're able to develop autoantibodies, and maybe that's how you can get ANAs and double-stranded DNA autoantibodies that are present. I mentioned this earlier. These are very rare to find, and when we do find them, I see them in patients that have very severe lupus, and usually quite severe lupus nephritis. It's not going to be so helpful for any sort of borderline cases where you're trying to figure out, is this lupus or is it not? And the immunofluorescent staining pattern here, we have our nice full house staining. And this is really only helpful when you have a patient that is naive to any therapy, right? If they're already on immunosuppression, then the full house staining really goes away. And so when you have subsequent biopsies or serial biopsies from patients with lupus nephritis, this is not a reliable feature to count on. And the EM is always just nice to be able to really localize where all the deposits are in the biopsy. Here we have a lot of subepithelial ones, and even plenty of subendothelial deposits as well. Endothelial tubular reticular inclusions. Here are some nice examples in this image. This is not specific for lupus, right? These are known as interferon footprints, fingerprints, footprints, and anyone that has an elevated interferon level, right? And you can see this. Patients taking interferon, you can see this in HIV, and other settings, but this is something that we do often see in the setting of lupus nephritis. And now we're moving on to the Chronicity Index, glomerular scarring. I mentioned how the Bowman's capsule often gets eroded, so that might be a hint that this used to be a crescent, and now it's completely scarred, so it represents more a fibrous crescent. And I have a ischemic glomerulus over here just to remind me that in general you want to avoid these glomeruli when you're assessing and trying to classify lupus nephritis, because as you can see, when the glomerular tuft kind of collapses, it can look like there's mesangial hypercellularity, but that's really not the case. This is just an ischemic glomerulus. And you can have segmental sclerosis or segmental scarring. I really actually try to avoid the term sclerosis, because then folks might start thinking that we're trying to say that there's also FSGS, or the primary form of FSGS, which I really don't want you to necessarily consider when you're reading my biopsy report on a patient that has lupus nephritis. And actually, that does raise the question of podocytopathies, which I won't specifically talk about now, but maybe we'll discuss potentially in the question and answer session afterwards. And again, here are some fibrous crescents. And when their glomerular capillaries are separated like this, you really can infer that this is a post-inflammatory response, right? This is very different from ischemic obsolescence, where the entire glomerulus shrivels down from that ischemic injury, and then you have collagenization of bone space. Interstitial fibrosis and tubular atrophy, just like with any disease, you can really see those atrophic tubules and sort of sparse interstitial inflammation that often accompanies that. And just a quick note also, because in the prior lupus nephritis classification, there was the distinction of segmental and global when you were assessing class 4 lupus nephritis. And it was defined in an anatomic way where less than 50% involvement of the glomerulus allowed us to invoke the segmental lesion, versus greater than 50% involvement was global. And so that's gotten removed. And actually, what was I thought useful about that was it reminded me to consider that posse-immune or ANCA GN could play a role in some lupus patients, right? Because 15 to 20% of lupus patients also have positive ANCA titers. And so that's something to keep in mind, because in some cases you might have predominantly, say, a class 2 lupus nephritis injury, but hey, there's a lot of crescents. And that sort of discrepancy, or if you had, a class 5 membranous lupus nephritis and a lot of crescents without all the subendothelial immune complexes, because it's really the subendothelial immune complexes that correlate with cellular crescent formation, right? Rupture of the GBM, because that's what's, leading to the influx of inflammatory cells. And like I mentioned earlier, the class 2 and the class 5 lesions, those immune complexes are kind of shielded away from the circulation, right? So this is something potentially to keep in mind. It's probably more of an academic pursuit right now, because we don't have therapies that are, say, so specific for a posse-immune injury that causes crescents versus one that's more immune complex mediated driven. But it's still, I think, useful to keep this in mind, and potentially one day maybe we will have some of those therapies. And I guess especially now that avacopan and some other drugs are probably in the pipeline, this might become more relevant down the road, right? And this is just an example of how the IF was not so impressive, and maybe mostly you're seeing mesangial immune complex deposition, and on the EM you see the electron dense deposits in the mesangial areas, and these subendothelial locations are really quite clean. And so if you see a lot of crescents, right, this really represents a discrepancy, and potentially there's a posse-immune process that's contributing to the crescentic injury. So for the pathology report, right, we clearly want to classify accurately the lupus nephritis. I Usually we'll also mention the extent of interstitial fibrosis and tubular atrophy when it's present. I actually will make a big deal out of tubulo-interstitial inflammation and tubular basement membrane complexes. And I think part of it is that here on the south side of Chicago, we have a lot of Black patients and they have very severe lupus nephritis. And we're seeing that their disease is a bit worse, and that we believe there is a biologic basis to that. And I'll talk a little bit about that when we discuss sort of the tubular interstitial compartment shortly. Clearly, if you have a vascular injury, that sometimes can really supersede all of the glomerular injury, especially if there's a TMA. That might be number one diagnosis, on my diagnostic line, which again, that's hard to do almost because we are so glomerulocentric when it comes to the classification of lupus nephritis. And certainly in the comments, I specifically like to call out the percentage of presence, even though it's present in my microscopic description. I want to try to make it as easy on my clinicians as possible. I certainly will mention the activity and chronicity indices, and if there are prior biopsies, we like to mention how it compares to those biopsies. Are there any questions that are popping up? We can potentially address them now, I guess. Otherwise, I can go on to class 5 lupus nephritis.
We do have some questions popping up. Yeah, it's totally up to you if you want to address them now or if you want to wait and do all of it at the end. What do you prefer?
Right, let's do it at the end. Okay. So class 5 lupus nephritis, right? Here's a nice example where we have subepithelial spikes on the Jones-Silver stain. Sometimes when you cut it on FOSS, it can have a sort of a vacuolated appearance. On the immunofluorescence, right, this really contrasted with the class 2 lupus nephritis, right, where all the deposits were confined to the mesangial areas. Here you can really see how it kind of outlines the capillary loops very, very nicely, right? And so the immunofluorescence often is quite characteristic for class 5 membranous lupus nephritis. And the EM really just kind of confirms that with numerous subepithelial deposits here. And it can occur concurrently with class 3 or class 4 lupus nephritis. There's really no need to diagnose a class 2 and class 5 lupus nephritis. Really, the class 5 supersedes class 2, right? Because for class 1 and class 2 lupus nephritis, you don't really need to treat those patients with anything in particular. But with class 5 lupus nephritis, folks will probably treat that. And this is where that's outside my area of expertise. So defer to all the clinicians in terms of how they want to treat those. But it was found that it doesn't matter if you have class 2 along with class 5. It doesn't change at least your prognosis for the class 5 lupus nephritis diagnosis. And I think, I'm sure you're all aware that PLA2 is obviously the major target for membranous nephropathy. And initially in this first paper in the New England Journal from Larry Beck and David Salant, they saw that lupus nephritis didn't seem to be involved with PLA2 at all. But I think subsequently to that, we've started to hear more about other studies that have demonstrated that this potentially is not necessarily the case. Here's actually a Spanish group that found that around 15% of their cases were PLA2 positive in their patients with membranous lupus nephritis. And there's actually also a nice study from India that also demonstrated that a really substantial percentage of their patients with membranous nephropathy and lupus nephritis were PLA2 positive. And one of the things, again, that I think is worth just keeping in mind is that lupus patients have lots of autoantibodies. So why couldn't they also have autoantibodies to PLA2, which it makes sense that they do, they can, right? And so that's something certainly that could be playing a role. And then, of course, our colleagues at the Mayo Clinic are really advancing our knowledge, Sanjeev Sethi in particular, regarding all the antigens that are involved in membranous nephropathy. And they've recently discovered that exocytocin 1 and exostosin 2 are involved in the autoimmune forms of membranous nephropathy. And even just more recently than that, they described that the patients with membranous lupus nephritis that were exostosin positive had actually less chronicity and potentially a better prognosis than those patients that were exostosin negative. And so, stay tuned. I think we're certainly going to be learning a lot more about this. And, if you've been paying attention on Twitter, I certainly waste too much time there. There's even now reports I saw that John Zuckerman had a patient that had PLA2 positivity, THSD7A positivity, and L1 positivity. I think we clearly have a cognitive bias towards Occam's razor, and this is where Hickham's dictum is going to come into play, and potentially these patients will have multiple antigens as we start looking more carefully for this. So it's really exciting in a way, but it's also kind of potentially is going to kind of give us muddy the waters a little bit in terms of how we should be thinking about this. But stay tuned. I think we're obviously going to be learning a lot more about that. So lupus, class 6 lupus nephritis is pretty uncommon for us to see, especially now that the definition states that you have to have greater than 90% of the glomeruli that are globally sclerotic. So it's pretty uncommon for us to see this now, unless, a patient shows up in the clinic, sky high, creatinine, you're not exactly sure what's going on, and maybe they're very young. So before you just tell them they have end-stage kidney disease, you might, want a biopsy just to absolutely be 100% sure. That might be some of the rare instances where we might run into class 6 lupus nephritis now. All right. And another thing just to keep in mind, there are some drug-induced forms of lupus nephritis, particularly hydralazine. We're seeing plenty of this, although usually more with ANCA GNs, but just recently in the last 2 weeks, I've had 2 patients where they were ANA and ANCA positive. And one of the first things I will ask now is, are those patients on hydralazine? And I'm now 2 for 2 in the last 2 weeks. So it's something to really keep in mind. That drug is a particular culprit. All right, so there you have it. The lupus nephritis classification, simplified, right? Hopefully not oversimplified, but certainly it is complex. And as you're dealing with sort of real life cases, it's obviously not going to be nearly as straightforward potentially as some of these buckets are being illustrated in this sort of short talk. Let's go on to the tubular interstitial compartment and then the vascular compartment, and then we'll wrap up shortly. We're really here in the home stretch. And so, as I mentioned before, interstitial fibrosis and tubular atrophy is the most important parameter in any renal disease, actually, in all renal diseases. In the Oxford IgA nephropathy classification, that was the most important parameter, superseding all the glomerular parameters, basically. But IFTA is basically an irreversible, injury. But on the other hand, you often have a lot of interstitial inflammation. So our group in particular has been very interested in the role that the interstitial compartment plays in lupus nephritis. And actually, a lot of this really dates back to this study. Gary Hill and his colleagues in France have this great study where they looked at 71 lupus nephritis patients, and these patients were willing to undergo serial biopsies that were 6 months apart. And they basically parsed out the injury in every imaginable way that you can think of. And they found that interstitial inflammation was one of the pivotal variables, which really, really important finding. None of the other ones really quite stood out in the way that interstitial inflammation did. And then this Chinese study in 2010 further demonstrated this finding. As you would expect, interstitial fibrosis and atrophy were independent risk factors, but so was interstitial inflammation. You can really stratify the outcomes of these patients based on the degree of interstitial inflammation. And then a couple years later, or a year later, we also here at Chicago looked at this and also found that interstitial inflammation correlated with creatinine, but not necessarily the titers of double-stranded DNA or C3 levels or the degree of glomerular injury. And in fact, the activity index in lupus nephritis class were actually poor predictors. And so here are patients that had no inflammation actually did fantastic, and those that had very severe inflammation did the worst, right, in terms of their renal survival. And you can see that this doesn't really separate when you're looking at activity index for these patients. And so when you look at this compartment, which we actually have in a little bit more detail, we found that you often can have diffuse interstitial inflammation or actually sort of organized lymphoid aggregates in the form of either T-cell, B-cell aggregates or germinal centers. And we were fortunate enough to be able to laser capture some of these lymphocytes and plasma cells from these germinal centers, and we were able to demonstrate that you can actually have intrarenal B-cell clonal expansion and somatic hypermutation. These ectopic germinal centers are actual functional. They function and they work, and they don't just look like germinal centers. And in our cohort, there was actually a nice correlation with the presence of tubular basement membrane immune complexes, which seems to correlate with a greater degree of interstitial inflammation. And I will recognize that in the literature, this correlation is unclear. But in our hands, we saw a nice correlation, and it may potentially have to do with our cohort here on the south side, where we do have a lot of Black patients with very severe lupus nephritis. Here's just an example of the diffuse interstitial inflammation with CD45, the pan lymphocyte marker. Here you can see with the pan T cell marker and pan B cell marker, CD3 and CD20, how these T and B cell aggregates really kind of coexist with one another, and they're presuming they must be communicating with one another. And then these ectopic germinal centers that show up in about 7 or 8% of our kidney biopsies that you can see. And here's a CD21 immunostain that demonstrates the follicular dendritic cell network. And so now you can actually add lupus nephritis to this list of other autoimmune disorders and the target organs, which can also demonstrate ectopic germinal centers. And so that's pretty interesting. And actually, ANCA GNs can have rare ectopic germinal center formation. I recently just saw one, which I was a bit skeptical, actually, because we see a lot of ANCA GNs, and I think I've never seen an ectopic germinal center, but I recently did just see one. But so that seems to be much more rare in that disease, but not so rare in lupus nephritis, I would say. And what's also not so rare is the presence of extraglomerular immune complex deposition, right? As we can see here with all these tubular basement membranes that are staining with IgG. And there's this nice study from Ohio State that demonstrated that actually the subclass profile, if you look at IgG 1, 2, 3, 4, can really differ when you're looking at the glomerular immune complexes compared with the tubular interstitial or the vascular immune complexes, which really suggests that there are two separate processes that are occurring. It's not really just sort of a spillover from the glomerular compartment, which really kind of fits with our current paradigm of how lupus nephritis is really operating. We believe that the glomerular injury really represents sort of systemic autoimmunity, and the tubular interstitial compartment actually represents local renal lupus disease, actually. And so my colleague, Marcus Clark, and his group have really pushed sort of our knowledge in this realm. And they've actually recently discovered that vimentin is a really common target in lupus nephritis patients. They've been able to actually, from the laser capturing of all these plasma cells, they've been able to sequence the variable heavy and light chain regions of these antibodies, and then clone actually, these variable regions into vectors with the constant regions, and then express these antibodies. And so they've been able to study these many antibodies from 8 different lupus patients. They probably have much more than 25 antibodies by now. And 5 of the 8 patients had auto antibodies to vimentin. This is just demonstrating that in the normal kidney, you have vimentin staining in the glomeruli and the podocytes, and really not very much in the interstitium. But when you have an inflamed lupus nephritis kidney, you can see a lot of staining for vimentin. Here at higher magnification, here are some presumed macrophages that also have a lot of staining as well. And this seems to correlate with severe tubulointerstitial disease in lupus nephritis. So the highest titers of anti-vimentin antibodies correlates with that in the lupus biopsies. So potentially this is a nice biomarker for lupus nephritis. So stay tuned with that. I think they've looked at another larger cohort and found that that seems to still be the case in this larger cohort of lupus nephritis patients. And so finally, let's talk about the vascular lesions. Vascular immune complex deposition is very common, and typically these vessels appear normal by light microscopy. By immunofluorescence, you can pick up the presence of these deposits, usually IgG and C3, C1q will light up pretty nicely. There's this other entity known as non-inflammatory. It's also in the literature. You can see vasculitis as a term. I prefer vasculopathy because this actually is not a very inflammatory lesion. And actually, I believe that this is analogous to the wire loop deposits or the hyaline pseudothrombi that can accumulate in the glomerular capillaries. Basically, it looks like you have prominent immune complex deposition that, for whatever reason, can accumulate in some of the arterioles. And so occasionally you will see that. And it's not to be confused with a thrombotic microangiopathy, because you can see here how uniform the staining quality is. And this is actually quite pink, and a true thrombus really doesn't have that sort of pink staining quality to it. And here we do have an actual thrombus or several thrombi in a larger vessel over here that are also involved by this thrombotic microangiopathy. So you can appreciate how it's much more heterogeneous, right? You can actually see a lot of the red cell fragments, and it's not the same homogeneous staining quality that you're seeing here with these immune complexes that can deposit in the vessels. This really would lead us to a whole nother topic, but certainly you would think about antiphospholipid antibody syndrome, because of course lupus patients have lots of antibodies, so why couldn't they also have that? Certainly, with one of my conflicts of interest, I'm very interested in the role of complement and how it contributes to this, and I believe this is actually a major contributing factor that probably is underappreciated most of the time. And certainly there's other things that you might also, that can cause TMA, but really it's these top two that are probably the main things to consider when you're dealing with a lupus patient that has a TMA. The largest Chinese study that has looked at the vascular lesions really confirms how common a lot of these injuries are. Certainly in TMA, they found in almost 1 out of every 6 of their lupus nephritis patients. And then you can see some of these other ones that are very, very uncommon. And vasculitis is exceedingly rare. And even this sort of non-inflammatory necrotizing vasculopathy is really quite uncommon. But they found that in their study, the TMA patients had the worst outcomes. I think there are probably too few patients in these groups to really be able to conclude anything. I would guess these folks likely didn't do very well at all. So I think with that, that is my last slide, and I really thank you all for your attention, and happy to take any questions. I'm sure there'll be tons.
Thank you, Tony. That was such a great overview, and there are tons of questions. Excellent. We have 11 minutes, and we can even go longer than that. Okay, so I'm going to open up from the Q&A here. It begins with Mario Rubin asking, there's an old paper from Rush that stated that both the activity and chronicity indices are not reproducible. What are your thoughts?
Yeah, if you start showing these biopsies to like 5 different pathologists, you're going to have a wide range. But when you have one or two pathologists that are looking at these, and I think it's not going to be so varied. We're the right intra-observer variability is much more narrow than the inter-observer variability. So, ultimately, can we convey if there's mild, moderate, or severe activity, or mild, moderate, or severe chronicity? I feel like, yes, we can. I know there's this huge push for having machines replace us and having that be more, more, reproducible, like your serum creatinine lab result. But I think we're a long way away from that. So.
Giovanna asked, is there a working group engaged in redefining the activity based on the comment that the score of 12 of 24 is not necessarily indicative of severity of disease? Do you know?
I'm not aware of that, actually. And I wasn't involved in that last revision for the lupus nephritis classification. I'm not aware that anyone's working on refining that activity index or the chronicity index. But I think this is where it's really important to communicate with our clinicians. If they're just reading your report, then this sort of, miscommunication could occur, right? I think for us, we always are chatting with the nephrologist and sometimes a rheumatologist and sometimes all of them together. And I feel like that is always a good thing, right? Putting all our heads together and understanding the context. And because again, the biopsy is a snapshot in time. I really need to understand what's happening, right? What has happened. And that allows us to really be able to paint a better picture for the clinicians. So yeah, I mean, there's always going to be shortcomings when you have arbitrary cutoffs and the difference between class 3 and class 4. 49% crescents or 51%, right? Maybe that would push one to class 3 or to class 4, but are they that different? Probably not, right? But if it's 5% crescents and 90% crescents, then yes, that is obviously much more different. So.
Right. Great. Okay. So next question. Sometimes it's difficult to differentiate diffuse wire loops from class 5 lupus nephritis. How do you differentiate these?
Well, I think this is where, and potentially, I guess maybe if you don't have EM to really help you, and I'm aware in a lot of countries the EM is not so easy to get, but this is where if you have a really good Jones stain, that's going to be super helpful, right? Because if it looks like a class 5 and it's that thick, you should be seeing spikes. You should be seeing a vacuolated appearance, right? If it's a wire loop, you shouldn't see that. And like I said on the H&E, if you focus up and down on those wire loops, they really have a nice refractal quality to them that really you feel pretty good about your ability to identify that once you get used to that. And if you look for it and then you see it, and you'll be able to identify it for the next case. So.
Yeah, I think that refractile nature of it is very helpful. Reem asks, in which category would you consider the tubulization of a crescent, cellular or fibrocellular?
Well, that's why we lump cellular and fibrocellular together. I don't really go nuts trying to separate cellular from fibrocellular. Actually, I'm kind of a lumper. I mean, there's enough there where you would treat and you would try to halt the injury. So yeah, I mean, I don't know what the truth is. I could tell you it's one or the other, and maybe the truth is the other of whatever I pick. So and I don't know that anybody knows, right? And in reality, I don't know that we need to know that, I guess. So there's enough evidence there. If you find that finding, they need to treat that.
Right. Reem had a follow-up question, and he apologizes that it doesn't relate to this topic. But he has a case of a 12-year-old boy with AIN, and the IF is negative except for vascular or granular C3 staining. Do you think this has any significance? Thank you.
Huh. Is this a lupus patient? that's complicated. No, I think that's we see restaining in the vessels all the time. So that's nothing, I guess. If that's what we have only, then that's just interstitial nephritis. Yeah.
Okay, next, when we have diffuse segmental scarring and spike reaction on light microscopy and subepithelial and mesangial deposits on EM, is it class 4+5 or is it class 5 with diffuse chronic changes?
Yeah, I guess if you're calling it class 4 and it was in the old classification C, right, for chronic, it's sort of, yeah, that's always, you can do it however you want, except, I mean, you just want to make sure that if there's no activity that your clinicians understand that, right, when you're calling it class 4. You don't want there to be that miscommunication of them thinking that there's activity and they'll treat that with toxic therapies when it's an irreversible lesion. But it's a great question. Yeah, when you have class 5 with a lot of chronic changes, is that really that it was just a class 5 leading to all the chronicity, or did you have an old class 3 or class 4 lesion that now has scarred down, right? I think there's no way for us to really know that necessarily to prove it one way or the other sometimes, especially again, where the biopsy is a snapshot in time, right?
Lynn has a question about class 5 lupus. What should be the cutoff point for class 2 with a few subepithelial deposits segmentally versus class 5 lupus with a segmental membranous pattern? How many capillary loops need to be involved to call it class 5? This is a practical problem and I'm not defined anywhere.
I think in the last classification, they said that you have to have more than 50% of the glomeruli with membranous changes, which, I mean, that's really, someone made that up, right? You just had to come up with a cutoff. I guess this is where, you know, where I sort of cheat a little bit. And, you know, if the patient has nephrotic range proteinuria, that might sway me more towards calling it a class 5 versus when they don't, and they're not, say, on therapy, then, you know, but yeah, this is the art of medicine, right, Lynn? This is, you know, everybody probably has a different way of approaching that. And yeah, you're right. There's no set defined way of how one should deal with that. But yeah, that's a tough one. I mean, if there's only a few subepithelial deposits and there's not nephrotic range proteinuria, I tend to not call it class 5.
Yeah. Okay, next question is, when counting the percentage of global sclerosis, do we have to differentiate global sclerosis due to lupus injury versus those due to other reasons, for example, atrophy or vascular compromise?
Yeah, that's almost also near impossible unless you can really be convinced that, hey, these are fibrous crescents with the, you know, Bowman's capsule being completely dissolved or something like that. And even that is not such a perfect way. I mean, it basically represents chronicity, right? And it certainly becomes more challenging as your patient's age increases. You know, in a 15-year-old, I could probably pretty safely assume all the glomerular scarring is due to the lupus nephritis, right? But in a 50-year-old, right, where you can have aging related changes, that certainly makes things more complicated. But yeah, I think luckily it doesn't matter, right? Because we don't treat chronicity. But it is an interesting sort of academic exercise in terms of trying to push our boundaries as renal pathologists. Can we make that distinction? I think maybe sometimes we can, but I would say a lot of times we can't.
Yep. All right. Prina Rastogi says, thoughts on renal limited lupus when the clinical team vehemently denies lupus, but labs are mixed with positive ANA and double-stranded DNA negative, but renal biopsy shows full house picture. Is that renal limited lupus?
Wow. What are you seeing in Iowa there? I don't know that I can't remember coming across that in a while. Yeah, that's a great question. I mean, I would be careful, right? I mean, this is where, again, if the clinicians are like pushing us to be the ones to like label the patient with lupus and lupus nephritis, I wouldn't want to do that. I would sort of phrase it in a different way: immune complex mediated GN, see my long comment. Yeah, especially if clinically they just say the patient does not have lupus. It's certainly possible that it will evolve into that, right? And so this is where I don't feel the urgency to be definitive when this process is still potentially in evolution. So.
Right. Okay, Neil asks, I noticed there's some inter-observer variations in estimating IFTA, and I was wondering, what is your recommended approach in quantifying IFTA?
Yeah, I mean, this is where I don't even like throwing a percentage on my biopsy reports, right? Where it's very much a sampling issue, and certainly, and this kind of goes along towards Mario Rubin's question at the beginning regarding the inter-observer variability for activity indices and the chronicity indices, right? Again, if you have a person, I would say I could feel pretty confident that I am consistent, right, in terms of how I would read the degree of interstitial fibrosis and tubular atrophy. But again, yes, if we start showing that biopsy to a whole bunch of people, then it's going to potentially be more varied. And that's just how it is. And, I know sort of, yeah, if you want to say, yeah, well, then now that means like renal pathology is BS. Well, if you want to make that conclusion, I don't know what to tell you, because it's not, right? I mean, it's clear that we are able to do semi-quantitative assessment and be reliable. I mean, there's, but I can understand how, potentially scientists want it to be even more precise than that. And currently it hasn't been, right? And until we get actually image analysis to be able to help us out, and I would love that. Until we have that, it's always going to be a bit of an art.
Yeah. Marco from Italy says, beautiful presentation. Is there a minimum number of Gloms that you need to have in your sample to apply the ISN RPS classification?
I always like to have more than 10. But if I have fewer than that, I'm still going to do my best. I might just have in the comment that, this might not be, this may not be representative of the kidney. And that's always a concern, right? So clearly the more glomeruli we have, the better. I think most people like at least 10, but I mean, if I have 5, I'm not going to say I'm not going to classify that. We're going to do our best, But you're right. If you have 5 and 2 F crescents, that's a class 3. Well, if you had 5 and 3 are crescent, right? The difference of 1 glomerulus, But we can play that game even if you had 100 glomeruli, right? So
right.
This is where the activity index and chronicity indices can potentially help. But yeah, I think it's important for the clinicians to understand that there could be a sampling issue, but we'll look carefully at the IF sample and we'll look carefully at the EM sample to make sure we're looking at all the glomeruli.
All right, so Mahiri says, this is a great question. What do you call patients who have clinically confirmed SLE, chronic changes on light microscopy, but IF is negative?
I mean, you could still call that sort of, right, the sclerosing type of phase of lupus nephritis. I think that's fine. Basically, there's no activity, right? So they wouldn't specifically treat anything in that biopsy.
Right. I do want to mention there are a few people asking who have internet problems. This will be posted on the renal, the RPS website afterwards, so you will be able to access this. Okay, let's see. We're at 11:04. Do we continue going for a few minutes or?
Fine with me. I mean, if people have to log off, they can log off. If you want to keep recording, that's fine.
Okay, awesome. All right, Rizwan asks, when you calculate the percentage of crescents, is the denominator total glomeruli, obsolete and viable, or is the denominator only non-globally sclerosed glomeruli?
No, it's total glomeruli.
Total. Do you mention the extraglomerular deposits of IgG on IF in your report?
I do when it's really prominent and there's a lot of interstitial inflammation. Yeah, I often do. I know I care about that more than probably most people. So,
yeah. Manjusha asks, is there a grading for tubular, interstitial, and vascular lesions in lupus nephritis?
No, not really. Certainly not for vascular lesions. Tubular, interstitial. I mean, we're grading it for the Chronicity Index for interstitial fibrosis and tubular atrophy. And you can do the same thing for the interstitial inflammation. That's really how we did it for our study when we were looking at the degree of interstitial inflammation. Even though it's somewhat imperfect, you can tell if it's less than 25% of the biopsy or 26 to 50% or greater than 50%, and that seemed to correlate with outcomes. And we specifically did not want to exclude the atrophic areas. We wanted to avoid that confusion that sort of, when we're looking at allograft biopsies, when you have to mentally subtract anything, I think it starts adding a lot more inner observer variability. And so we wanted to get rid of that. And so I was glad to see that it was able to be predictive when you're assessing total interstitial inflammation.
Okay, I'm going to switch over to the chat thing now, where we have a few more questions. So Yael is asking, I'm wondering why the classifications 82, 2003, and most recent haven't really formally included the tubular, interstitial, and vascular compartments. Do you have any comments?
Yeah, that's a good question.
Maybe they will in the future.
Yeah, so to leave room for further revisions. Yeah, I don't know. Yeah, that's a great question. I think it should be, or at least we should start working on it, because it just gets then overlooked and set aside, and really thought that it's not as important. And yeah, we really need to, especially, I mean, now recently we have some drugs that are approved for lupus nephritis, but for a while we had so many failed clinical trials, and I kept thinking, I wonder if we're even looking at the right compartment. We're not even paying attention to the interstitial inflammation and what it's doing there, and are looking for some of the changes there. Yeah.
Fadi is on, and he asks, Tony, regarding completely fibrous crescents, for fibrous crescents that are globally involving the glomeruli, do you count them as globally sclerosed glomeruli or as fibrous crescents?
I mean, if you can feel confident that they're fibrous crescents, I'm fine with lumping it there, but sometimes it can be hard. But yeah, it sort of doesn't matter in a way. One way or the other, it'll get counted and go into the Chronicity Index. But yeah, it can be challenging to make that distinction, especially when they're really, really old. So yeah.
A couple people asking about lupus podocytopathy. If you have any words about that, and is there any way to diagnose it without EM?
Yeah, and then particularly if those of you are on Twitter, Astrid Wines just tweeted about her study with the anti-nephrin antibodies that they're picking up in minimal change in some FSGS patients. I think these are data that she presented at the most recent Kidney Week, in 2020. And again, lupus patients have autoantibodies, so why can't they also have podocyte targeting antibodies? And it looks like they can, or they do, or potentially they will if we start looking in the setting of lupus as well, right? And maybe autoantibodies targeting cytoskeletal proteins, and certainly the slit diaphragms and all these things. So yeah, I feel like that makes sense, that probably is playing a role. I don't see how you can establish that without EM. You really need to see the EM to see the effacement of the foot processes. I mean, this is one of those things where, yeah, if your biopsy looks really clean, right, and you don't have class 5 lupus nephritis, but you have a lot of proteinuria and you don't have crescents and all these other things going on, and you're just looking for an explanation, then yeah, you certainly will start really invoking potentially a podocytopathy. But if you have a lot of crescents and whatever, I mean, the proteinuria can be coming from, right, ruptured GPMs, and who knows what else is going on there, right? And certainly if you have class 5 lupus nephritis, then that explains your proteinuria. But yeah, if you have a really clean biopsy, then looking for reasons for why you have proteinuria, then yeah. Another thing to really keep in mind also, though, is that if your creatinine is fluctuating, right, and if you're relying on the protein creatinine ratio, that can be really potentially skewed in the setting of acute kidney injury, then that could be misleading as well. So it really is worth understanding, are we looking at a 24-hour urine collection, or what is the time frame? Sometimes the proteinuria has been detected, and by the time you biopsy, maybe things have gotten better, but they haven't necessarily rechecked the protein creatinine ratio, or, that sort of thing. And so understanding that context becomes really, really critical too.
Lynn wanted to clarify her earlier question. So the 50% of capillary loops, this is about the membranous component. The 50% of capillary loops with a membranous pattern is for calling something class 5 plus 3 or 4. But for class 5 alone, you only need a segmental membranous pattern. But how segmental isn't defined as far as I know, but I might not know.
I don't think it's defined. This is the art of medicine, Lynn. And you're now an expert. You get to make up whatever you want, and people will believe it. And I will totally believe it if you say so. So yeah, I think we're certainly in a real gray area. And yeah, this is where I'm sure it could even vary from patient to patient, right? I mean, there's so many factors that potentially could be, and then a sampling issue, how many glomeruli are you looking at in your EM, and all of that, and how many loops are you looking at, and all that, yeah. Right. So that can be really challenging. I mean, I guess I have the advantage of scoping my own EM cases, but so I can feel a bit more confident about what is actually there. But yeah, I think that it's hard. This is where, when you have these buckets, there's going to be certain cases that maybe don't quite fit in your definitions, right? But maybe, I mean, this is like where our definition of thin basement membrane nephropathy, right? If we use a cutoff of 250 nanometers, if the patient's GBMs measure 255 nanometers, I'm not so sure that's not the explanation for the hematuria, right? I mean, who's to say that in a given patient, maybe that's thin enough? Maybe in another patient, that's not thin enough. Who knows? We don't know.
The art. The art.
Sorry, Lynn. I wish I could give you a more definitive answer, but I think that wouldn't be the truth.
Right. One question just popped up. A known case of lupus nephritis having Congo red positive amyloid deposit. Should we report it as lupus nephritis and renal amyloidosis? I had this recently. That was interesting.
Yeah.
Yes.
Yeah. Two different diagnoses. Yeah. Sure. Yeah. The amyloid wouldn't be a part of the lupus nephritis as far as we can tell. And that's a great point. You can have diabetic nephropathy. You can have all sorts of other things. And certainly, whenever we see organized deposits, I feel like we probably should raise the possibility of cryoglobulins more. Certainly with the wire loops and the hyaline thrombi, lupus patients can have cryoglobulins, and that serum test is really unreliable, right? So I think we probably don't do that enough even. I'm sure I don't do that enough, but I certainly try, just to remember that, it's the whole Occam's razor and our cognitive bias towards trying to lump everything together when maybe that's not always the case.
Right. And especially in lupus, a chronic inflammatory state, like, yeah, I've seen a couple cases of amyloid A in lupus nephritis. So
yeah, that's a great point.
A question from Sherry: how do you differentiate lupus nephritis, a lupus nephritis associated TMA pattern versus TMA with SLE?
I'm not sure I understand that question.
I'm not sure.
If you have TMA, then yeah, the clinicians really need to think about antiphospholipid antibody syndrome, and frankly, for me, complement, overactivation of complement. That's certainly my bias, but I believe this starts to explain why our Black patients have worse lupus nephritis. Their complement system is too good, and that is really underappreciated for the most part. And so, yeah, the TMA story, that's a whole nother lecture. I can talk about that for a whole hour, actually. But the way we currently understand it is probably incorrect. But we're learning more about it. And now potentially we have therapies that can target that and potentially help patients. So sorry for that vague, cryptic sort of answer, but yeah, I mean, if you have a TMA, that's really important. I would say that potentially trumps the lupus nephritis, actually. Those patients,
yeah.
If that doesn't get treated, right, and you're depriving the kidney of blood flow and oxygen, that's going to lead to bad stuff.
Yeah. Okay, we'll wrap up in a minute. There's one question that just popped up. How different is pediatric lupus nephritis compared to adult lupus nephritis in terms of prognosis?
Yeah, that's a great question. And we see a lot of pediatric lupus nephritis, actually. But I mean, this is where I think there's a real positive data, right? Because even though in lupus you tend to potentially get serial biopsies, we even then, right, don't get a lot of serial biopsies, especially as the patients get better. And the pathologists always want to know, right? But obviously you wouldn't subject your patient to that. And I do believe that the younger folks have probably more regenerative capacity than we probably give the kidney credit for. So, and certainly I think there's anecdotes of, hey, you have a biopsy in a young patient with lupus that has a lot of crescents, and then potentially you biopsy years down the road, and you don't have the same amount of scarring from, say, the degree of crescents that you had right in the prior biopsy years earlier. So maybe there is, potential reversibility. Although in a setting like that, you could say, well, you're not looking at the same glomeruli or the same nephrons or whatever, but we can only kind of guess or, use that as an estimate. Yeah, I think the younger folks have a bit more regenerative capacity potentially, but that's just my gut feeling. I don't know that we have a lot of data to support that.
Right. Okay, last question. You've actually gotten through all these. That's very impressive. What do you do with patients who have established SLE clinically, thickened glomerular capillary walls without spikes on light microscopy, but show a membranous pattern on IF rather than full house staining? I'm trying to figure that one out.
So, meaning you want to make a diagnosis of more of like a primary?
Yeah, I think that's what the question is. Yeah.
I guess. I mean, this is where the whole primary secondary membranous, I think, is falling apart already, right? I think we practically know all the antigens, so we should get rid of the whole primary secondary from our heads. And especially in lupus, right? If you have a PLA2 positive membranous in a lupus patient, why isn't that secondary to the lupus? Right. Lupus patients have autoantibodies, so why is that a primary membranous? It could be secondary to the lupus. So this is where you can make your head spin in crazy ways if you rigidly want to stick to the whole primary versus secondary framework. That's, I think it's very clear in membranous that we need to stop doing that. From a practical clinical standpoint, I get that, you know, the clinicians need to understand how do they approach something. And so then that framework has been helpful for them. But going forward, you know, as we gain more information, that framework really is going to fall apart very, very quickly. I think it already has. It's kind of in shambles. And so if you're trying to cling to that, it's like a sinking ship. I think it's not worth clinging to.
Okay. Oh, we have one more that just popped up. Thanks.
We've been all day.
All right, we're ending with Sherry's question. Another question is, have you seen IgA nephropathy in lupus patients? Is it rare?
I don't think I have, but I wonder if you're talking about, say, the secondary IgAs in the setting of cirrhosis or liver disease, where actually you can get what looks like full house staining, and I've seen that misdiagnosed as lupus nephritis. And so, because in that setting, you can get C1q staining, C3, you know, and there might be a little bit of IgG and IgM, and you could potentially call it a full house and lupus and all that stuff when there's no clinical evidence of that at all. So in the setting of liver disease, potentially there's overlap with sort of the full house staining and some of the lupus nephritis features. So, yeah.
Well, I didn't mention, but there are lots of comments also popping up that are people that are very appreciative for this wonderful talk. So thank you so much.
Yeah, and you guys, you know, feel free to reach out, email me, and DM me on Twitter or whatever. I'm happy to interact and learn from everyone else as well. So.
Yeah, thank you very much, Tony, on behalf of the RPS. Thanks for doing this. We've had a huge amount of interest. So people were obviously, yeah, very interested in both the topic as well as the access to your expertise. So thank you. And thanks to Kammi for moderating the very lively Q&A session. So as Kammi mentioned, a recording of this webinar will be available on the RPS website within the next week or so. And the final thing I have to announce is that the next installment in this patient webinar series is on April 16th at same time, 8 a.m. Pacific, Central. Neeraj Kammi from Stanford University will be talking about the pathology of diabetic nephropathy. So with that, yeah, thank you all again for joining and participating, and we'll talk to you again in the future.
All right, thanks everyone.
Thank you, Tony.